Good morning or afternoon, depending on where you are in this world. I'm Dr. Heather Herdman. I am the Chief Executive Officer of NANDA International, and I'm very excited to join this seminar and to host Dr. Christine Spisla, who is going to talk to us about kind of continuing the conversation about SNOMED CT, which she began in her first seminar with us. That was very well received, and we got lots of questions and follow-up for. So the format today will be simply that Dr. Spisla will do the presentation. I will be monitoring the question and answer at the bottom of your screen. You'll see a Q&A opportunity icon at the bottom. So if you have any questions, please feel free to put those in there. I will monitor those as we go along. And then when she finishes her presentation, I will bring those questions up to Dr. Spisla for her to respond. So with that, I am very happy to step aside and turn this over to Dr. Spisla for her presentation. And we'll see you again at the end. Thanks.
Thank you, Dr. Herdman. Good morning, everyone. Good afternoon, good evening to wherever you're joining us from. My name is Christine Spisla. I'm the Director of Informatics here at NANDA International. If you are rejoining us after our first conversation and on the introduction of SNOMED CT, welcome back. If this is your first time joining us in our SNOMED CT discussion, do not worry. I will make sure that you are all caught up. And with that, let's get started. So in our presentation today, I will do a quick SNOMED CT refresher to make sure everyone is on the same page before we take the dive in and just start discussing documenting the nursing process. And then we'll finish up with how you can get involved with SNOMED CT and NANDA and the NANDA Informatics Committee. So let's get started. So SNOMED CT is actually an acronym, and it stands for Systematized Nomenclature of Medicine Clinical Terms. It's had a long history. It is currently in use by over 40 countries around the world. And since the 1990s, the nursing documentation has been represented within SNOMED. I always have to give a shout out to Florence Nightingale, because even back in the days, and that date is incorrect, it should be 1896, my apologies. But even back then, she recognized the value of nursing documentation. And even to this day, we're trying to get it right and to do justice and to document the value of nursing within the patient record. So when we talk about SNOMED CT, we're talking about four things. And these four things encompass everything about SNOMED. We're going to talk about concepts, descriptions, hierarchies, and relationships. And these four components provide a logical definition for each SNOMED term and helps describe and helps codify the patient record and the patient story. When we talk about concepts in SNOMED, we're talking about a unique idea, a unique thought, a unique thing with a unique identifier. So here in the center of the screen, we see we've got a concept ID, and that ID all by itself has no embedded meaning in it. And associated with that code is a human readable term. And together, the code plus the human readable term enables meaningful queries for secondary use for our clinical documentation. So not only describing the patient journey, but then using it for research to improve patient outcomes and any other kind of research. What a concept is not, and so when we talk about what a concept is, we also have to talk about what a concept is not. And it is not a long narrative about the patient, because within this narrative is embedded multiple concepts. It's also not a complete sentence. When you think about some of the standardized nursing assessments that we do, many of them do contain complete statements. So we've got to be wary of that when we're trying to enter these types of assessments and these types of nursing documentation within a standardized reference terminology. Concept does not mean different things in different situations. So administering pain medication by protocol may mean one thing in the emergency department. It may mean another thing in an ambulatory physician's office or a clinic. And it is also not disjunctive, because we're including multiple concepts here, because infection of the skin or mucous membranes, are two different concepts, because infection of the skin is not infection of the mucous membranes. And so we've got two different concepts that may or may not be correct about the patient of record. So you'll never find anything similar to this in SNOMED. So looking at the concept, everything here within the screen, within our red box, is part of the SNOMED concept. And we're going to talk about the descriptions and relationships as well, just a refresher. So when you're talking about SNOMED, it's the SNOMED identifier and then the human readable terms that are used to describe that identifier, plus the relationships that provide definition for that concept. So let's talk more about descriptions. And as I said earlier, descriptions are the human readable terms that are linked to that identifier. Within SNOMED, the fully specified name is that unambiguous way that we use to describe that concept. And that unambiguous way includes the hierarchy tag. And so you see here for myocardial infarction, we have a hierarchy tag of disorder. And that disorder tag resides within the clinical findings hierarchy. And everything that has a disorder hierarchy tag is a necessarily abnormal clinical finding. And then SNOMED also provides a number of synonyms, because they recognize that there are a number of different ways to describe a concept. And those synonyms are there to help you navigate SNOMED and to find these terms within SNOMED. You're not going to see every possible variation of it. You're not going to see every word order variant of a term in SNOMED, because that would just be combinatorial explosion, but it's there to help you find different ways of saying the same term. And so let's talk about hierarchies. In SNOMED, there are 19 top-level hierarchies, and that seems quite daunting, but truthfully, you're only going to use a handful of these hierarchies. Many of these hierarchies are there for administrative purposes, are there for concept modeling purposes, and are there to support the modeling of other SNOMED concepts. So the most commonly used hierarchies in SNOMED are the clinical findings hierarchy, where you're going to find things about your patient, your diagnoses, your normal and abnormal findings about your patient, about the community, the procedures hierarchy. So these two hierarchies are the ones where we're going to find the bulk of our nursing documentation. And we're also going to use the events hierarchy. Now, the events hierarchy used to be part of the clinical findings hierarchy, but there was an editorial decision made a while back to remove the events and put them in their own hierarchy. And so what you're going to find in the events hierarchy are patient falls, death, and any event that happens to the patient. The pandemic, I think, of the COVID-19 pandemic has been added to the events hierarchy. So it's not a large hierarchy, but it is used, especially in nursing. The organism hierarchy is used for pathology and laboratory, and the substance hierarchy is used a lot of times to describe allergies. Because with allergies, especially medication allergies, you are allergic to the active ingredient or one of the ingredients within that medication. You're not allergic to the pill or the lotion or the cream or the solution itself. So now let's talk about relationships. Relationships help define our concepts, and we have two different kinds of relationships in SNOMED. We have the subtype hierarchy of the subtype relationship, which is the hierarchy where that concept resides. So you also hear it called the ISA relationship or the parent-child relationship. And it specifies a concept that is a subtype of another concept. So as you go up the hierarchy, these concepts get broader and more general. And as you go down the hierarchy, these concepts get more and more specific. And it links the concepts within a hierarchy. So that hierarchy, the clinical findings hierarchy, the procedure hierarchy, the events hierarchy, is part of the logical definition of that concept. And it answers the question, what kind of thing this is. Whereas the attribute or the relationship hierarchy provides further detail on that concept. And we get that further detail on that concept by linking across to other hierarchies. So when you have, for example, fracture of the right ankle, the ankle structure, because it's going to be a fracture, and the fracture has a finding site of the ankle, we're going to find that ankle concept within the body structure hierarchy. And it provides more information. So what is the site of this procedure? What is the site or the of this clinical finding? So between these relationships, the subtype relationship and the attribute relationship, we get the definition of the concept. So these concepts don't have another embedded definition for them. Now, one of the things I want to caution people is often, and when I was working with the SNOMED terminology directly, people would write in, end users would write in, and they would say that under myocardial infarction, they could not find the symptoms of myocardial infarction. So the symptoms of myocardial infarction is part of the knowledge model. And that is not what SNOMED represents. SNOMED gives you the words to use, and the words to use consistently across sites of care so that we can share and compare clinical data. The symptoms would be part of that knowledge model. So, and also when you have symptoms, not everyone has every symptom of a disorder. So that's not SNOMED's role. That's not SNOMED's job. So here within our example, where the relationships provide the definition between varicella and shingles, you can see that they both have a causative agent of the herpes virus, the human herpes virus, but it is the relationships that provide the definition to differentiate between varicella or chickenpox and shingles. So I want to stop right here. Heather, do we have any questions at this point?
We do not have any questions at this point, no.
Okay, so let's move on and let's get into the fun part of this presentation. I wanted to make sure everyone was on board and had their arms around SNOMED before we dove in. And so now let's talk about documenting the nursing process. So when we talk about the nursing process, first thing we do is we do that patient assessment. And from that patient assessment, we use that knowledge that we've gained to synthesize that nursing diagnosis. And that nursing diagnosis is the driver for the care that we're going to provide for that patient. And that diagnosis drives the care plan, and the care plan, the documentation of our nursing interventions, and then also the outcomes that we hope to achieve from the patient's clinical status and the effects of our nursing interventions on that patient. So where do we find the concepts within SNOMED to document this? So when we talk about a nursing assessment, and we do a lot of nursing assessments in the United States healthcare system. The nursing assessments are essentially a question with corresponding answers. And the combination of the question plus the answer provides that clinical judgment where we get that nursing diagnosis from. So our question here is skin turgor. What is the skin turgor on the patient? So it's going to be that label within either your flow sheet or your form that you're filling out. And then your drop-down answers are going to be the drop-down list, or the boxes that you check are going to be the answers for that question. So we need to decompose that a little bit more. Back before in my previous life, I worked with a rare disease researcher, and she had asked us to encode her registry of rare disease registries with SNOMED CT. And what we found was you can ask the same question in so many different ways. And if the way that you ask these questions influences how you're going to code the questions and answers within a standardized reference terminology. So if we look at the upper right-hand corner of the screen here, the question is, what are the comorbid conditions? And the answers each have checkboxes. Whereas if you look at the bottom right of the screen, we are asking the exact same information, but we're asking it in a different way. And our answers from the first example actually become the questions from in the second example. And then our answers, then we need to synthesize that yes, cardiac disease exists, or no, cardiac disease isn't present, or it is unknown if cardiac disease is present. And so those are different answers than just saying, the patient has cardiac disease. And then similarly, on the left side of the screen with the delivery history, same thing. The way you represent the questions and the answers, and the way that you break them down impacts how you're going to code them with a clinical reference terminology, such as SNOMED CT. So hopefully here, I've kind of gotten you thinking about how your clinical documentation is structured and how you're asking these questions within your clinical documentation. So within the United States, the National Library of Medicine and the National Institutes of Health have created what they call the Common Data Element Repository. And within their research, they recognize questions and answers, and they've created a repository of question and answer sets, which they call common data elements, for researchers to reuse within their research. So when they're reusing these questions and answers, they're not reusing the answers that came out of that previous research. They're just within their research, they're using the same structure of the question and answer sets, so that when their research is being published and they can aggregate the knowledge that's coming out of this research, they can compare and harmonize the findings out of this research to synthesize additional knowledge, because they can share and compare that information that came out of it, because they asked the questions the same way. So they're gaining the same knowledge. So this is just an example I'm showing you of why the questions and answers within your documentation matter. So how do we code that? Where do we find the concepts within SNOMED to code that? So we're going to table assessments for a little bit, but for the planning that we're doing, for the nursing diagnosis, that's always going to come from the clinical findings hierarchy within SNOMED CT. And this is where you're going to find the NANDA nursing diagnoses within SNOMED CT. There are other ANA, American Nursing Association, recognized nursing terminologies that have also been added to SNOMED over the years, and who also have nursing diagnoses as part of their documentation system. And all of these nursing diagnoses will be found in the clinical findings hierarchy. Nursing interventions are things that we do for our patients. They're things that we do on our patients. They're administrative, they are hands-on, they can be educational, it's the things that we do for our patients. And so all these nursing intervention terms that we use in our documentation and in our care plans will be found in the procedures hierarchy. The procedures hierarchy contains the procedures, the things that we do for our patient. And nursing outcomes are going to be found within the observable entity hierarchy within SNOMED CT, or if you're in the United States, we use the LOINC terminology for that. And we're going to talk about this a little bit more. So, but first, before we talk about that, I want to talk about the underlying principles for how the nursing terminologies were added to SNOMED CT, because this is going to help you when you're searching SNOMED for those nursing language terms that you're looking for. And when the nursing terminologies were initially added to SNOMED, it was a big project and it was fun. And when we looked at the nursing terms, the nursing language terms, if that concept was identical to an existing SNOMED CT concept, that was great. You know, it was there. We didn't have to do anything else. But I do want to caveat that with before the IHTSDO, the International Healthcare Terminology Standards Development Organization, which is now known as SNOMED International, was created. The SNOMED terminology was managed by an organization called the College of American Pathologists. And the College of American Pathologists, when they were managing the SNOMED terminology, had a way to tag SNOMED concepts that were linked to the nursing terminologies. So when a concept was added to the SNOMED terminology, we added a little tag on there so we could tell you what nursing terminology was part of it. And then if you wanted to see all of the NANDA terms within SNOMED, we could provide you with what we call a nursing map that would show you all the NANDA terms and their equivalent within SNOMED CT. And so initially when we were adding these nursing terms, when there was identical to SNOMED, it was there and we added that tag that I was talking about. When the concept was a synonym, when the nursing concept was a synonym of an existing SNOMED term, we added that nursing term as a synonym to that existing SNOMED concept, which is why if you're looking through the terminology, you can see some of the nursing terms as synonyms attached to the fully specified names. And if that concept was new and it was not within the SNOMED terminology already, we added it in there, and it's in the terminology using the term of the nursing standardized terminology that asked first. And then if there are terms that are shared among nursing terminology or concepts that are shared among nursing terminologies, you'll see those synonyms from those different nursing terminologies. So this gives you a little idea of how we added the terms into SNOMED, and that will also help you when you're searching SNOMED to find your terms for your nursing documentation. So here for the nursing diagnoses, we have an example of a nursing diagnosis, and you can see it's in, we have a clinical findings tag. We have a number of synonyms in there, and these synonyms may have come from other nursing terminologies that say the exact same thing, but say it just a little bit differently. And then on the right side of your screen there, you see the defining attributes, which are providing definition of effective breathing pattern. And on the top, you see the parents, and the parents are those ISA relationships, or those, so the parents are going to be more broad than that concept of that we're discussing right now. So hopefully, like, this is all coming together for you now. So let's move on. We're going to talk about a nursing intervention. Same thing here. And this is a little bit I chose this one because it's a little bit interesting, because not only do we have a number of different word order variants or different ways to say catheterization of the urinary bladder, but we also have some different ways of spelling it. And so this is called, these are dialects, and this is the United Kingdom or the UK dialect. And this is also how in Europe, if Europe is documenting using English, they are most commonly using the UK dialect, so they can find that that spelling variant in there as well. And we can see here that this concept, the parent concepts, which are the ISA relationships, are more broad than our concept that we are discussing. We have defining attributes that are providing more information and helping provide the definition of catheterization of the urinary bladder. And then this concept also has children. So as you go down the hierarchy, you can see the children concepts are more specific than our catheterization of the urinary bladder concept, and that our parent concepts are more broad. And this is how you go up and down the hierarchies. You go up and look at more and more parents, and then you click on them and you see the children. And these screenshots are taken from the IHTSDO SNOMED browser, which I personally, that's the one I'm used to using, and I find the most user-friendly as well. So as we move on, so nursing outcomes. So I want to stop here and talk a little bit, because I've had a number of conversations with a number of nurse informaticists who think, and especially in the United States. So there was a movement to move a little bit away from individualized care plans for the patient, and for patients who came into the hospital for certain conditions, pneumonia, hip replacements, hysterectomy, they created something called a critical pathway, which was a predefined care plan, and it created a path for the patient. And on day one, the patient would do this. On day two, the patient would do something else. On day three. So the care plan and the nursing outcomes became a little bit diluted. And nurses that I've talked to recently have confused outcome indicators with nursing, with the actual nursing outcome. So here on the left-hand side of the screen, there is the definition from the nursing outcomes classification on what a nursing outcome truly is. And it's a continuum that we measure the patient's response to their disorder, their condition, or the nursing intervention that we provided. So one of the conversations I had, someone was saying that normotensive is a nursing outcome, and I said it is not a nursing outcome; it is an outcome indicator. And so that is a conversation I think we need to continue to have and to revisit what a nursing outcome is. That being said, internationally, the nursing outcomes are mapped to the observable entity hierarchy. However, in the United States, the regulations are that we map this to LOINC. So this is where I want to stop and talk about this for just a second, because right now there is a movement in work being done in SNOMED International to integrate the LOINC terminology within SNOMED. Currently, the work is focusing on lab LOINC, which is all the lab procedures and then concepts for the lab results. your lab reports, your pathology reports. And eventually the work may move on to the clinical link. So that being said, the right now observable entities in SNOMED do not have defining attributes, but stay tuned because that is being worked on. So we've talked about question and answers. We've talked about the care plans. Now I want to move into how to map to a reference terminology. And I think this is kind of a bonus because a lot of people think they know how to map, but when it comes down to it, they don't know how. And there was a research project done that compared 3 different organizations, outside organizations that mapped to SNOMED and mapped their findings. And the output of that research project was very telling, because a lot of people, they look at their source concepts, their list of terms, and we're going to call your list of terms, your nursing documentation, we're going to call that the source. And the target terminology is SNOMED. So when I say target terminology, I'm talking about SNOMED. So people do word matching, and they jump in and they say, look, I found an exact match in SNOMED. I did the mapping. But I'm going to show you, a little bit about how that really doesn't work. So why do we need mapping rules? So just like building a house or just like learning how to drive a car, you need a clear plan out how to move forward. You need clear, unambiguous instructions for how to map which terms in which situations. But it's only not there for the mapping project. It's also there for maintenance, because once you map, you also need to maintain that map, because standardized reference terminologies are dynamic, and SNOMED releases twice a year, and there's changes to the terminology. So anytime that there's a release to your target terminology, you need to go through and make sure that your map is still current and you don't have any deprecated or retired concepts in your map. Or if you had something that you weren't able to map previously, there may be a new term there, a new concept that you can now map to. And it provides provenance for the map owners. They know where this came from. And it also, and like I said, the source and target terminologies are dynamic. Your nursing documentation may change. You may be adding new terms or taking away terms from your documentation as well. So like I hinted to in the previous slide, mapping is more than just matching the words. Now, my example on the left-hand side of the screen comes from the paper documentation days. But here is a skin assessment. Our question is, skin, what is the skin color, or what's the skin condition? And then here, let's look at our answer of pink. So, and I have here on the right side of the screen a screenshot from the SNOMED CT browser. And I entered the word pink in there because I wanted to see what I came up with. And I came up with 2 instances of the word pink. And notice, and they're not duplicates in SNOMED, because if you see the hierarchy tags attached to each of those, they're different. Pink color is a clinical finding, and then pink color, the other pink, is a qualifier value. So we didn't talk about the qualifier value hierarchy. And the qualifier value hierarchy in SNOMED is one of those hierarchies that I talked about earlier. They're there to support the other hierarchies. The qualifier value hierarchy is a list of adjectives. And on their own, they don't mean a whole lot. But they are there to help fully define and provide values for those defining attributes when you're fully defining a SNOMED CT concept. So in looking at how would I map the choice of pink, I wouldn't use pink color, because pink color can be anything. I'm trying to think, some things might, some things pink might be a good thing. Some things pink may not be a good thing. But what I would use is about 2/3 of the way down the screen, we have, or down the list there, we have pink skin with a hierarchy tag of finding. And that's the term that I would use to map to my little checkbox there for pink in my skin assessment. So I'm just going to take a second here just for you to kind of take that all in and understand why. So why didn't I choose pink color on its own? And I didn't use pink color on its own because when you're doing that secondary use of the data and you're doing your data queries and you get your query back and it says pink color. Well, pink color can be applied to a number of different things. So your query data is going to need a lot of cleanup, a lot of work to become usable versus if you map to something like pink skin, you know exactly what that concept meant. And so what your query for on your clinical documentation is providing you with a meaningful query return. So let's talk about the components of a heuristics or a mapping document, because this is really important. It is not just a list of, hey, map this to this, because what you're providing is the documentation of what you did and why, not only for your team or the group that is working on the terminology now, but also the terminology in the future, once you as the mapper or the leader of this mapping project has moved on to other projects. So your heuristics document needs a use case. And this says how your users will intend to use your mappings. I was part of a mapping project for a client, and the concepts we mapped to were specific to the PACU and ICU. So in this, we did not have any terms that would represent, let's say, obstetrics, because that was out of scope for our project. And that's what the use case would define. It would state this project is mapping the terms that are used in the PACU, is the post-anesthesia care unit and the intensive care unit patient population. No other population, just those patients. And it's defined what is included and what is not included in the mapping project. And so we were doing the nursing mapping, the nursing documentation. We weren't mapping anesthesia. We weren't mapping respiratory therapy. We weren't mapping the physicians. We were mapping just the nursing. The scope of our mapping project was for the nursing terminology. So for data governance, it is who owns this mapping set? Where did it come from? Who owns it? And who can I go back to in case there's issues with it? The target terminology states, I'm mapping to SNOMED CT. That's it. Nothing more. Maybe you want to say why you map to SNOMED instead of another one. And maybe you want to say we focused on having NANDA nursing diagnoses within our list of nursing diagnoses. We specified the NANDA ones. That would be part of your target terminology. And then you want to document which version of that target terminology you were mapping to, because, like I said, SNOMED releases every 6 months. Now, once you start a mapping project, it's important to stay with that version of the target terminology, because things do change. And once you are done with that mapping project, that's when you go back and you review it against the newest version to see if there's any changes, and then you make those changes. Because if you don't change versions of a target terminology within that mapping project, you are introducing error if that is done. Mapping specificity talks about the quality controls, and it also talks about it also talks about the QA process that you did with that. And it talks about, it starts to provide the rules, or it introduces the rules that you're talking about. The quality controls, the validation process, and it talks about, anyways, let's move on. So the mapping rules talks about, are you going to map one-to-one? Are you mapping one source term to one target term? Or if you have a very complex source term, and I gave you some examples very early on in what SNOMED is not. And if you have one of those complex statements, clinical statements that you're mapping to SNOMED, you may have to map one of your source terms to many SNOMED terms. And this is in the mapping rules, you define that and the implications of this. With talking about the target term, are you mapping to retired target terms allowable? And this kind of goes back to the mapping versions, because if you find that you've mapped to a target term, this is where you say, if a retired target term is found, what do? We have to go back and we have to switch that out. We need to find an active term in our target terminology to map to. So in our nursing documentation, often we will use qualitative or quantitative terms. So we will say the edema is 1 + 2 + 3 +, or we will say the lochia is scant, moderate, or there's copious sputum. These terms, scant, moderate, 1 + 2 +, may mean different things in different situations. So your mapping rules need to define and need to state how this type of source terminology is going to be mapped in this project. And then there are, if you have any project-specific rules, this is where these are defined. And ideally, you're doing an analysis as part of the data governance and looking through it. And these project-specific rules are usually discovered when you're kind of doing the prep work prior to the mapping project. And once the rules are always locked down once a mapping project starts. I was part of one mapping project. I was not the mapper. I was part of the validation process, and the organization doing the mapping. We started out with, I believe, 12 or 18 mapping rules, and we finished the project with 55 mapping rules. And we kept telling them that this is wrong, but that's what they wanted to do. So that's all we can do is tell them that it is not best practice to do that. So that's just throwing that out there. Mapping pilot project may be done if you have a very large data set that you're trying to map. And this is where you can test out the rules. Are my rules consistent? Are my rules sufficient? Do we have full coverage of all the different mapping scenarios in our mapping rules? Because like I said earlier, once you start the mapping project, the rules are locked down. You cannot add rules as you go along. And our mapping heuristics components also are, mapping heuristics also include what to do about unmappable terms. Is this bad source data, or is it just that the mapping, your target mapping terminology doesn't cover this term, and do you need to request a new term from your target terminology? Your mapping rules talks about your quality assurance processes, and your maintenance strategy. And then also it gives you a little bit of provenance, who created your value set, how it was validated, and where everything came from. And like the slide says, and this is for maintenance purposes, and it's just there for once you have moved on, that the people who are taking over for the project have the information. So I've done a lot of talking. Heather, do we have any questions in the meantime?
We do not have questions at this time, no. Just as a reminder, everybody can put your questions or comments in the Q&A section at the very bottom of your screen. You just click on it and you can type in anything you'd like to share.
Yeah, so SNOMED is, it is daunting at first. And I still remember when I was introduced to SNOMED and I thought, my goodness, but as you become more and more familiar with it, more and more familiar with SNOMED, just take a look. One of the things I do encourage people to do is go into the SNOMED browser, and on the screen here, I do have the link here on the third bullet point is the link to the SNOMED browser. Pick a nursing term that you like, and put it into SNOMED. In the search box that does completion matching. So if all you need is 3 letters, the first 3 letters of each word, and see what pops up. If you put too much information, or if you put the full term in there, sometimes it's so specific that you won't find it, because the concept, the idea, the thought that you're thinking of is represented using different words in SNOMED. So start looking through the terminology, and then go up and down the hierarchies and start looking at those terms and what's there, and the coverage in SNOMED. I've spent hours just going up and down the hierarchies. There's so much information there. But while we're waiting for questions to come, I do want to say that this SNOMED CT terminology does have a nursing clinical reference group. We meet on the second Tuesday of every month. We're going to skip over May, but we're going to meet again in June, and we've got the link to that, our Confluence page, where you can see the discussions that we've had. And it gives you the link to the Zoom call. And also, if anyone is interested in the NANDA Informatics Committee, I've got my email address is right there. Please do not hesitate to reach out. I'd love to chat and start a conversation on SNOMED or terminologies in general with you.
So, Christine, I have a question.
Yes.
Thinking about SNOMED CT from a NANDA perspective, what are the things that NANDA members or the association should be considering or thinking about in terms of making us more visible within the SNOMED CT terminology?
Heather, that's a great question. Well, first of all, NANDA was one of the first terminologies that was added to SNOMED, and I've done a kind of a look through, and I've done some QA, and there's the bulk of the NANDA terminology is there. What we had our we meaning the SNOMED CT Nursing Clinical Reference Group had our business meeting in April, and we had as a guest speaker the diagnosis Director of Nursing Diagnosis, Dr. Camila Lopez, as our guest speaker, and she went through the process of how nursing diagnosis development. I think with right now, what's going on with that is we need voices in this group to say, we use NANDA, we use SNOMED, we use NANDA. We need the updated NANDA terms within SNOMED. We need the SNOMED leadership to understand the importance of the creation of a NANDA ref set within the SNOMED CT terminology as important to the nurses who use SNOMED. So it's that voice that we need, that representation.
And so joining this, the clinical reference group, is the best way to facilitate that, or how would we facilitate that?
That is the best way to facilitate that. And then also by joining, that is the best way to do that. And I'm thinking about the SNOMED leadership that we work with, and then also through your through your National Release Center. If you're not finding the NANDA terms that you want within SNOMED, to request those terms to your National Release Center, because the National Release Center, and that is the within your country, the organization that is responsible for releasing SNOMED CT to your country. They are the ones that manage the requests for new content, and those requests do get pushed up to to SNOMED International. And if if the clinical authors who manage the terminology start to see that a term is being requested by multiple countries, then they start to consider adding that to the international version of SNOMED. So we need voices to request missing NANDA terms on multiple levels, not only at the international level, but at the National Release Center level, for those to be added into SNOMED.
So that's something that sounds like all of us can do.
Everyone, we have the power. We have the power. We just have to tell you, or just kind of give you permission to raise your hand and ask. Great question, Heather.
That is all I have for questions at this time, but I know for me personally, I really appreciate the presentation from Dr. Spisla. It's always exciting to hear her talk, and I always get ramped up when she's done thinking we need to do all these things. But I think what you have raised for us is, this isn't going away. I sometimes hear people say, oh, that's just a phase, and 5 years from now we won't have to worry about that. Well, it's been a phase for a long time. So I think SNOMED is pretty much here to stay, and nursing has an opportunity to make sure its voice is heard, and so that's on each and every one of us. And I actually think from a research perspective, it's very exciting in that, especially your point about the questions, how the questions are phrased is so important, because what you put in the system will determine what you can get out of the system. And so having that ability to search terms, knowing exactly how they're set up and where they come from, offers a plethora of opportunities for researchers down the road. So that's exciting. So I think we will close for now. And and just to let you know, you've got a great presentation from one of the participants. So thanks for that. And I think that we can continue this conversation. Certainly, I do encourage those of you who are interested to get in touch with Dr. Spisla about the Informatics Committee. We are definitely looking for people who are interested in working with her on that committee and helping us to move things forward. And we will have this posted on our YouTube channel as well in the future. So please keep an eye out for that, and send links to people that you think would be interested in her presentation. And you can also contact her through the email address that she gave you on her last slide. So anything else you'd like to say before we close, Christine?
No, thank you everyone for taking time for joining us today. And for those who are going to be watching this later on, thank you for your attention to this. And I look forward to working with you in the future on the NANDA terminology and SNOMED as well. Do not hesitate to reach out. I am here and would love to continue the conversation some more.
Great. So with that, we wish you a good rest of your day or afternoon or evening, wherever you are in the world. And thanks for joining us. And we'll see you at our next seminar. Take care, everybody. Bye-bye now.